Good evening, everybody online and the people who are here tonight at the Clinica London Academy. A big welcome. We're absolutely delighted to present Minak Bhalla, Mr Minak Bhalla, consultant ophthalmologist. He's from the Royal Free Hospital, but he works with us at Clinica London. He's one of our latest additions to Clinica London, and he's going to talk to you tonight about glaucoma. He's going to present some interesting cases, and he's going to make it very interactive, ask you questions, and at any time, if you want to ask questions during it, send in, for those at the webinar side of things, your message. And for those of you here, put your hand up and we'll bring you your microphone and you can ask your questions. Please go ahead. Thank you.
Thank you. Hi, everyone, and thank you, Jane, for the kind introduction, and welcome to everyone here and those at home as well. So today, as you can see by the title, I'll be talking about glaucoma cases, and to make it more interactive, it'll be about case presentations, as well as what the outcomes were and what we could have done differently at different times. So as Jane mentioned, please do feel free to ask any questions, and I'm happy to be interrupted during the presentation to answer them the best I can. So no real relevant financial disclosures. So as I mentioned before, today I'll be talking a little bit about each case. We'll have a brief discussion about those cases and what the outcome was, and actually probably touch upon some of the theory behind it as well, and what could have been done differently, and what I actually personally and the team learned from those experiences. And I really wanted to think long and hard about what are we going to gain from this talk and this CPD event. And actually what I really wanted to do was highlight those words in bold. So I wanted us to recognize some of the clinical signs about progression in pseudoexfoliation. I also wanted us to analyze what we do when we have visual loss and disease progression. How do we evaluate that? How do we learn from this, and how do we stop this from occurring again? How do we appraise our management options? How do we evaluate, as I've already mentioned, when it comes to different surgical options like minimally invasive glaucoma surgery? And finally, from the theory that we learn, how can we apply this to future cases as well? So the first case is a very interesting case of a 76-year-old Asian woman, and she attended my NHS practice. But before I tell you a bit about where I intervene, I'll tell you a little bit about her story from when she started. So she had actually been in our NHS clinic from about 2023. She was labeled as a suspicion of glaucoma. She had a history of short-sightedness, but other than that, actually, there was no other relevant family history, no other risk factors that were of any concern from medically or ocular-wise. When she was seen in August 2023, you can see that the vision was okay, borderline on the right eye and pretty good in the left eye. Her pressures were quite high when she presented, and actually that was the reason of her referral as well. On their examination, they found the angles were open, and one of the optic nerves did look suspicious of glaucoma. So they diagnosed glaucoma. They labeled this on our electronic records as glaucoma, so they weren't very specific about it, and that was that. And you can see these were some of the visual fields that were done, and it's pretty obvious to look at the right eye. The areas of darkness are areas that she was missing when she was performing this test, and so there was some damage that was functionally being shown on those tests. So what happened then? Well, they started some drops and the pressure actually responded very well. She was sent to our diagnostic hubs. So at the Royal Free, we have this really great diagnostic infrastructure to ensure that we can meet capacity and only keep patients who require urgent treatment within our clinics. And those that are stable can be sent to the virtual clinics where they have all their tests, and then myself, along with my consultant colleagues, will review the notes and write to the patient. 4 months went past, and actually her pressure rose again, and she was booked back into the face-to-face clinic. And at this moment, the patient was getting all these correspondence, and she was a bit perplexed and a little bit anxious that we had given her treatment, and yet the pressure had risen again. So she wasn't really too sure what was going on. As a result, she went and saw one of my consultant colleagues privately. And when she went there, her pressure had risen even further. So my colleague, who did a very thorough examination, actually put a label on her glaucoma as pseudo-exfoliation, which we're going to talk about a little bit later. The treatment was escalated and her drops were increased. So she was on monopos and she was added another drop, which was a combination medication. Some of you may have heard is Cosoft. Soon after, her pressure had dipped a little bit and she was considered as responding quite well to the new drops. And she was advised to continue. So her journey went on. So this is where I kind of started getting involved. So when she first visited, she was seen by our hospital optometrist. And she was seen by her on the first visit and the second visit. So I kind of put this question out both to the audience at home and those here. What would you do in this case? So when she attended the first time, her vision was 618. That's not too dissimilar to back in July. And her pressure's roughly about the same, actually. Not much had changed. And this was her OCT findings. At this moment in time, what are you guys thinking? Is there anything you would do differently?
I'd want to know if there is cataract there or not.
Great question. So she'd already had her cataracts done a good few years ago. So she was pseudophakic in both eyes. Anything else?
Do you go gonioscopy and see what's happening at the angle?
Yeah, very good. So that was conducted again by our optometrist, and they found that the angles were open. So yeah, you're in line with what we were doing at the time.
So was the refraction done?
The refraction was not done. No, that wasn't. Right, she has a history of being short-sighted now. So that is something we should look at. And actually, if you look at these images, there is a bit of a myopic tilt on those discs, and that can actually influence our scan results. So that is a really good thing to do, but we know she is quite short-sighted. Good. And these were the visual fields. So if you look at the right eye, I would believe this is probably getting a little bit worse than what it was before. It looks like there's a question from home.
There's a question from home. What about the colour vision?
Very good. So that's a great question. We didn't record that, and that wasn't in the EPR, but that is something that should have been done. Absolutely. Yeah. And what we noticed actually when the visual fields were done was that the visual field was getting a little bit worse. This wasn't quite commented on at the time when I look back at the notes, but the area of darkness on the right eye had got worse, especially centrally. And that was cause for concern. So what was our outcome? Well, what we did at the time was we checked whether the patient was compliant, which she was. She was taking her drops regularly and with the frequency we asked her to. Had she informed the DVLA? Very important question to ask and inform, and she had. And actually, at that point, we were satisfied. So my colleague who saw her to continue.
Did anyone think about scanning her?
No, so no one scanned her at that point. So what the working diagnosis there was that this is all part of the glaucoma and no scan was done. And she was told to come back in 4 months. Visit 2. So you see her again about 4 months later. The vision's changed a wee bit on the right eye, dropped by a line, and the pressure's crept up. Would you be doing anything differently at this stage? And this is both to the audience here and at home.
I think I'd go for a scan of some form.
Yeah, any scan in particular?
I'd want to see if there's a mass or even if there's any chiasmal lesion.
Yeah, that's a really good shout. And that's something we should always be thinking about when it comes to patients who present with visual field defects. Sometimes one of the errors that are made in medicine is that we focus on one diagnosis, and we don't quite think outside the box. And we should always remember that neurological defects of visual field are quite important to consider. Yeah.
From home, check her colour vision, please.
Yep.
And do the MRI with contrast.
Absolutely. So again, that's a great suggestion, something that was not done. And so again, still no colour vision recorded at this stage, and no scan was done. So further visual fields at 4 months. As you can see, that central fixation of darkness was getting worse. The left eye, roughly about the same. OCT scan, probably not too different. So if we go back a little bit similar to before, not a whole load different. Perhaps some of the numbers had got worse. And this is what was written in our electronic notes. Stable visual fields. Yeah.
Age-related macular degeneration, my
Yeah.
goodness.
So pressures within normal limits. Perhaps some of the changes were related to age-related macular degeneration. And the actual OCT scan, perhaps there were too many artifacts for to consider that there was a progression. And again, we wrote down review in 4 months. So in April, I've started my consultant job and I get presented this case. And this lady's vision's dropped to 660, a significant drop. Her pressures are quite high up at 38 as well, and 32 in the left eye. Pupils are sluggish, color vision is down, and she's got a cupped disc. And we can see from that visual field that that central area of defect has got worse and now is impeding her vision. And this is what I did. I basically looked back at her notes and looked at what her vision was doing and what her pressures were doing. And the key aspect that I realized was that we were seeing a generalized decline in her vision in the right eye. So that final point was the latest vision, which was 660, but it was going down. So there was a trend for the vision to be reducing. And similarly, when I looked at the intraocular pressures, it was having these spikes. So you can see that she has a high pressure point, and then we give her some treatment, it reduces, and then it goes up again, and then it goes down again. And she was now heading towards another spike, which was causing significant damage. So when I met this lady, I obviously was very, explained to her what was going on. I was very apologetic that it had taken us so long to actually do something that would have helped prevent this. As soon as I saw her on that treatment, I offered to add oral Diamox. So that's acetazolamide. So this is a particular tablet that we can give patients to bring their pressure down. However, we don't leave patients on this tablet for too long because it can have systemic effects that can be detrimental to the patient. And what I discussed with her was listing her for urgent surgery. She was having these spikes despite being on treatment, and these spikes were slowly but surely damaging her optic nerve. And they had damaged it to an extent that her vision was being affected. And that's one of the sad things about glaucoma. In glaucoma, the damage occurs, we can't reverse it. So it's down to us to recognize this as early as possible, to prevent us from to prevent patients from reaching a stage and for us to help them as soon as possible. She was understandably upset, but we had an action plan in place. So I wanted to show you a video of the surgery that I did. And this is a PreserFlow. So this is a small micro shunt that we insert in the eye. And what this does, it acts as a drainage device. So the excess fluid that's forming within the eye is drained through this small micro shunt. And it drains and keeps the aqueous, which is formed within the eye that's causing the high pressure, to remain underneath the conjunctiva. And obviously it's not as fast as this in real life, I've edited it, but this normally takes roughly about an hour to do. And once you've closed up, hopefully with the shunt working, it'll continue to drain the fluid and it will minimize any pressure spikes, which this patient was predisposed to. And this is what happened to her vision. So after carrying out the surgery on her right eye, I very quickly did the same on the left eye to ensure that doesn't happen. And her left eye was now a better, stronger seeing eye. And actually, this is probably what shows the most effect. So you can see at the point where I intervened and subsequent follow-ups, the pressure was controlled and she was no longer getting these spikes and of high pressure. And actually, we had optimized everything and her pressures were stable and the curve was plateauing. I last saw her back in August. She was about 20 weeks following her right operation and about 12 weeks following her left. She was off all the drops. She was no longer having any pressure spikes and her vision had stabilized. But most importantly, because we had recognized this and intervened, we now had a left eye vision, which would hopefully stay as it is, and the right eye wouldn't be getting any worse. But unfortunately, she had lost an amount of vision where she would only be able to see probably 636 or 660 on her Snellen chart. And at the next visit, we'll be repeating some of the tests to see how her diagnostics are performing following the surgery. Any questions?
This is fairly new.
Is it a fairly new treatment?
So
Because I've
the
not heard of it.
PreserFlow is relatively new. Yeah, not as new. It's been around for a while, but it's not as old as, say, the trabeculectomy, which was, which has been around since the 70s. PreserFlow probably in the last 15 years or so, and it's been used quite, quite a lot now amongst certain sets of patients. There's still a lot of debate about the results of this particular surgical procedure, but generally speaking, from my colleagues and those around in London, more and more of my colleagues are using this as a first-line treatment.
Why did you go straight for the PreserFlow instead of a trabeculectomy? That's a question from those sitting comfortably at home.
Yeah, and again, that's a great question. So the reason I went for the PreserFlow is, in my hands, actually, the PreserFlow has shown pretty good outcomes. Often with trabeculectomy, there is a slight risk that you are more predisposed to getting certain complications. And I've always felt that the PreserFlow probably gives you better control in preventing this. Now, there are some subtypes of glaucoma, like normal pressure glaucoma, where PreserFlow is never going to be able to achieve the low pressures that you would get with a trabeculectomy. So I was being a little bit risk averse when I went with the PreserFlow, and I wanted to make sure that this lady who had this operation was at the lowest risk possible of achieving any complications that she may get with a trabeculectomy. So that was my reason.
Is there any way in the assessment of her that you could have picked up those fluctuations in pressure? Are there any continuous pressure reading mechanisms, or how do you do that?
Yeah.
Apart from have them in the outpatients all day?
Yeah, that's a great question. So the only one that's really available at our disposal, which is probably not done as commonly as it once used to be, was phasing. So as you mentioned, keeping patients around and checking their pressure every hour may have given us some idea that she was fluctuating during the day quite a lot. And that was one way. But the other way was perhaps just focusing on the notes and looking back and looking at the trends that were recorded. So often in busy NHS clinics, we are trying to get through patients and we can negate. And sometimes it just means actually taking a moment, looking back at the notes, looking back at the previous pressures, and seeing how the patient's doing may have given us the answer sooner.
A question from home. Why was, I think it's trabeculectomy, it says trabeculectomy. A question from home. Why was trabeculectomy, I think that's trabeculectomy, not done sooner, as both visual fields were declining, or no, one visual field was declining.
Yeah.
So why was the intervention not earlier?
Yeah, correct. So I guess that's probably one of the learning points of this. When the patient was reviewed originally by one of my colleagues, it really wasn't escalated to any of the consultants, and the patient was just deemed stable because the pressures were within normal limits. And even though we were seeing visual fields declining, this just wasn't flagged up.
So the moral is if you see visual fields declining, it's
Absolutely.
not see in 4 months' time,
Yeah,
it's action.
absolutely.
Another question here. How long does PreserFlow keep the IOP lowered?
Yeah.
How long does it keep it lowered?
So that's a great question again. So the PreserFlow data is showing promising signs. It all really depends on the patients that you pick. So if you have someone that is not at high risk of scarring, those patients will often have good pressure for a longer period of time than those that are high scarers. And what I mean by that is if you have patients of certain ethnic backgrounds, are male, are younger, they're more likely to scar, they're more likely to probably impact the outflow, and those pressures are likely to begin to rise. She was an elderly lady, she was of Asian background, but I use the PreserFlow in combination with anti-scarring agents like mitomycin, which we use in trabeculectomy, as well as Avastin, which we sometimes use in macular degeneration. And both those anti-scarring mechanisms combined help keep her pressure low. But, she's still less than a year, so it'll be interesting to see how she does as time goes on.
Another question. At which point in the patient's clinical journey would surgery have been more beneficial to the right vision?
Yeah, that's a really good question. So when should we have intervened? And I believe either at visit 1 or visit 2. If we had seen those notes and acted around that period of time, we may have been able to preserve her vision at around 612, 618, rather than let it get to 660.
What's the advantage of PreserFlow as opposed to armored valve?
Yeah, that's a great question as well. So armored valve comes under the category of an aqueous shunt. And PreserFlow, you could almost combine it with a trabeculectomy. They are bleb-forming procedures. You could jump straight to an aqueous shunt, but if that doesn't work further down the line, then it's very difficult to go back and do a bleb-forming procedure. So if you want to take the stepwise management, then you want to do a bleb-forming procedure first, which could either be a trabeculectomy or a PreserFlow, and then go on to an aqueous shunt after that. But there are certain clinical scenarios in certain patients where you can do an aqueous shunt off the bat. Great. So pseudoexfoliation, we've probably all seen this clinical image before when we think about pseudoexfoliation. It's a syndrome that primarily occurs in patients of Scandinavian background, but actually can also be found in places like Turkey and Greek, the Mediterranean countries. It's age-related, and it's often defined as dandruff-like material that gets deposited, but not only on the eye, you can see it gets deposited on different organs around the body as well. However, as ophthalmologists, we see pseudoexfoliation in the eyes. And whilst we don't really know the true mechanism as to why it occurs, other than it being genetic, what we do know is that it can impact patients' pressures, as we've seen. It can impact patients' surgeries, like cataract surgery, because it can make the lens quite wobbly and can make the whole procedure a little bit more challenging. Can be bilateral, asymmetrical, and often find an equal predisposition to both sexes. The genetics, it's basically found that it can inhibit one of those enzymes, which actually helps synthesize and make the elastic fibers stable. And because that enzyme's not working very well, you get these deposits around the eye. So what's the consequence? Well, I've talked about some of them already. You can get cataract complications. You can have high risk of severe glaucoma as well. And you can get poor control of pressures. And so when you're looking out for patients with pseudoexfoliation, what are the signs that you see? Well, we've talked about the dandruff deposits, but these are some of the other clinical signs that you can see. So you can have deposits on the cornea, like I've shown here. You can have iris changes as well. And when you start seeing these signs, you should have a low threshold to think about pseudoexfoliation, because these are the very patients where the pressures can vary quite a lot and patients can deteriorate quite quickly. And if you're able to go near as well, what you can do is look at the angle and see that it's quite heavily pigmented. What are the consequences of pseudoexfoliation? Well, we've seen already, patients can present with very high pressure, They can have high variability, and those fluctuations can be quite damaging. They often have quite severe damage to the optic nerve. And actually, when you look at their original presenting pressure, that can often be quite high. So what do we do? Well, you should treat these patients like every other pressure patient. You should start off by giving them drop therapy. There is some arguments about doing laser as well, but these patients are at high risk of having high pressure spikes when they have laser. So you can give that therapy, but you often have to do 180 degrees. And often, if this is not controlled with either laser therapy or drops, these patients often end up going down the surgical route, as this lady did. But it's all about intervening at the right time. So the one condition that we're all familiar with is primary open-angle glaucoma. That's what the vast majority of our clinics are made up of. And how does pseudoexfoliation differ with primary open-angle? Well, like I said, pressure could be higher at diagnosis, more fluctuations, can be slightly asymmetrical. It can have quite serious progression as well. And they're at higher risk of blindness. And on occasion, they can be quite hard to treat as well.
There was one last question about
please.
surgery, if you could take
Yeah,
that before
absolutely.
moving on to your next case. It's a combination of what would be the best next surgical treatment option, and secondly, can you do a second micro shunt later down the line?
Yeah, good questions. So generally speaking, if you are doing an operation which is blood forming, and over time, if that stops working, the next step is often to either try and revise that particular operation. So you go in and you can break up all the scar tissue that's preventing the shunt from working. Or if it's been a longer period of time, then you would consider doing an aqueous shunt, like an armored valve or whichever aqueous shunt that you do at your hospital. Can you do a second micro shunt? If patients are low scarers, perhaps, but generally speaking, and I'm probably speaking from the demographics that I deal with, which is London, it's not something I have done or will probably likely do going forward. If this particular operation fails, then the next step is to do an aqueous shunt.
And last question, is it more common in Scandinavian people because of this genetic link?
Yes, correct. Yeah. So that genetic link is found very commonly in the Scandinavian population. And obviously through historical migration, you found links in Greece and Turkey as well. So we move on to case 2. And this is of an 89-year-old Caucasian woman. She was a very interesting woman who presented to my clinic. She had very advanced primary open-angle glaucoma. She too was on pseudophakic, but she was on everything. She was on drops as well as the tablets. Now, one of the issues of being on this Diamox or acetazolamide tablet, as I mentioned earlier, is that you can generally have a really bad reaction to this tablet, which can impact your kidneys and can make you feel quite lackluster, fatigued, and I've seen patients get quite sick of it. So whenever I see patients on this, especially those that are elderly and have been on this for a long period of time, alarm bells ring, and my main objective is to see what I can offer them to take them off this particular tablet. She had had previous trabeculectomies, which were no longer working, so that's why she was back on this medication. She too was a high myope, and she had a couple of drop intolerances. So you can see our options were very limited at this stage. This was her vision, 612 and 69, and her pressures were 21 and 23. Her eyes were quite injected because of the drops and the toxicity that the drops bring. Her blebs were flat, they weren't functioning, so the trabeculectomy was no longer working as we would like. And the optic nerves were pretty advanced, which is in keeping with her diagnosis. And when we look at the visual fields, you can see each of those dots represents a visual field. And again, there's a downward decline in both eyes. And this lady's 89. Her social situation is that she's independent, lives by herself, does everything by herself. And she's reaching a stage where she has a small island of vision left. And actually, should that go, she would be in big trouble. She may not be able to fend for herself, and she may lose that independence, which has kept her going all this time. So what do you do in this instant? She's actually not keen on any intervention. She turned around and said to me, I don't want anything done. There's been a whole load of surgery done in the last 15 to 20 years on my eyes. Please don't do anything further. She's struggling with drops due to arthritis. And she can't be on that tablet for very long. If those were her pressures with that tablet, imagine what the pressures would be off those tablets. They'd probably be higher in the 20s, maybe even in the 30s. So again, the question goes out to those here and those at home. Is there anything you would be thinking about?
Possibly refer to LVA clinic?
Sorry?
Possibly refer to an LVA clinic or a visual aid clinic?
Yeah, absolutely. That's a very good piece of advice and very good comment. Those clinics are very useful and a huge aid to us because they help provide patients with support, with items that can help them navigate around the house and stop them from having falls and stop them from hurting themselves if their vision is markedly reduced.
Prepare for social services to intervention
Yeah.
with house needs and things, because obviously the person's probably going to be falling down and bumping into things now.
Yeah. So we all know that patients, especially elderly patients who have falls and can fracture their hips, their recovery is long and the morbidity and mortality does go up for these patients. So opening that conversation to discuss with the patient that this could be potentially something that we have to, process and think about, and start that conversation not only with the patient, but perhaps even with their GP.
Do you have to register them?
Yes, absolutely. So that's another really important part. So when you see visual fields like that, you should think about registering them so they can get the support that they need as well, both financially and from services like low vision aid and social services.
So all this that you just said is because she said that she wasn't willing to do anything. If she was willing, what could you have done?
Yeah, great
Because her
question.
VAs are very good.
Yeah, and that's what we're going to get on to. But honestly, this is very common. I see this a lot in patients who have had a lot of operations done to their eyes, and they reach a stage where, one, they believe that they're too old to have any further operation, and they really don't want to go through that stress, which is totally understandable.
We've got an at-home question. How about cyclodiode or micropulse diode?
Yeah, great. That's a really good option as well. So both of those options are really good. Doing a cyclodiode would help reduce the pressure. So that targets the ciliary body from outside. Micropulse is a variant of that, which isn't as aggressive and showing good results at the moment. And both would have kept the pressure down, and that would have been a very viable option for her as well. So when I saw this patient, I did discuss a few things. I actually didn't discuss the laser. And I said, look, we have the option of not doing anything at all. There is a chance that you could lose vision as this goes on if we don't intervene, or the Diamox could harm your health. We could do quite a large operation, which, I mean, I barely had spoken the words of a large operation and she shut me down, which is, again, understandable. So I didn't really go down that avenue at all. And then the other thing that came into our mind is, could we put in a small microstent in the eye? And these microstents are, they're in fashion at the moment. A lot of patients are having these done with their cataracts, and they're showing good data that actually with cataract surgery, when we put these microstents in, they can help reduce the pressure. They can help patients come off a drop. And that is quite good because it can bring them down the ladder of treatment. It's a fast operation. It will take about 5 minutes in each eye. And it can be topical, so she doesn't have an anesthetic that could take the vision away. And it could help us remove the tablets, which was worrying me quite a lot for this patient. So after much discussion, she agreed with this, and we went ahead and put a small stent in. And this was what I did with this lady. So I there are many different types of microstents, and these are stents that target the drainage part of the eye. And so I placed a hydrostent in, and this is an example of how we did it. So the stent is in an injectable. Once you see the view of the drainage angle and you target the trabecular meshwork, you engage with the trabecular meshwork, which is part of the drainage angle. And you may just see the view is not the clearest, but this small microstent goes in and keeps that trabecular meshwork open and allows access for aqueous to flow through without any resistance. So I saw her a couple of weeks. Vision was no different, but actually her pressures had come down a little bit, and that was off the tablets. So as soon as I placed that stent in, I told her to come off the tablet to see how she would do, and she stayed at a reasonable level. So now she's only taking the Monopost and the Tiopex. These are two different medications, which she's happy with, one in the morning, one in the evening. Potentially, I could even combine those in the future so that she's only on one bottle, and she was just taking her post-op drops. This is what the stent looks like. It's obviously much smaller than this, but this is taken off one of the other slides from the company. But what it does, it creates an access point for fluid to flow through the trabecular meshwork into Schlemm's canal and into your venous system. And how I describe this to my patients is that when you have a drain, it's like you're in your sink, putting a stent in to keep that drain open. And in essence, that's what you're really doing with this as well. And the metal that it's made of is quite malleable. And there are variations of this. So you will hear of eye stents, hydruses, and there's a whole load of other stuff that's exploding in the world of minimally invasive glaucoma surgery. And all of them are showing some evidence that actually it does reduce pressure, but this is much debated. So the advantage of using this particular microstent is that it bypasses the resistance of the trabecular meshwork. It has a 90-degree span, so a larger surface area to cover, and it scaffolds, so it keeps that area open for flow. And this is the other variant. So this is a eye stent, and this is another option that one can use. And this again does the same thing as the Hydrus microstent, and the results have been quite similar with both of those.
How long does the stent last? Do you need to replace it or?
Lifelong.
Lifelong.
Yeah, it's lifelong.
Is it done on more patients now than before to take them off the drops?
Yeah, absolutely. So it's now becoming an option for any patient who is on glaucoma treatment and they're having their cataracts done. If your hospital does do it, or in privately, if you're going to go that way, you should offer this as an option for patients to come off their drops if they wish to. And so often these patients are open angle glaucomas or high pressure glaucomas. And if they're on 2 or 3 drops, by adding a stent and removing the cataract at the same time, you can help lower the pressure and maybe take them off 1 or 2 of the drops. But
Is it available on NHS?
Yes, it is. Yeah.
It is?
Yeah.
Okay.
These are all NHS patients.
I was a bit surprised that the MIGS was introduced so late in the game. I mean, why was she on these Dimux medication when you know that she can only be on that temporarily?
Yeah, I suspect patients' resistance. I suspect that this was an option that wasn't considered. Perhaps that was another reason. But we were really looking at anything we could do to get her off Diamox. I was almost thinking outside the box to see what I can do to help her.
A couple of questions. One is the material of the Hydrus microstent and iStent made from, is it MRI safe?
Yes, it is. Yes, that's again a really good question. So it's not one of those devices whereby you would have to report it when you're having an MRI, or it's magnetic. And likewise, if you're going for airport security, it's not going to ring the buzzer.
And in the longer term, Is this a lot cheaper than keeping people on drops and tablets?
Yeah, it is much better for them. So often with drops, patients who take it for a long while, they get a lot of side effects from the drops. Yeah, and the other aspect of drops that we may not appreciate, I certainly find very difficult, is that a lot of these drops do look alike. And if you're elderly, you have arthritis, differentiating between those, making sure that you're able to take them out and put them in a timely manner, and your life revolves around your drops, and that's not a great quality of life to have. So what I try and do is try and use as many dual combinations as possible so that they're on as fewer bottles as possible to make it easier for them.
Is the outflow much greater in the Hydrus as opposed to the iStent? Noticing that the measurement in one was 80 microns and the other was 216 microns.
It's very debated. So this particular trial with the results that I've highlighted was a very good trial that showed actually the Hydrus did its job. Head-to-head trials have shown not much difference between the two. Yeah. And this is just a little bit about the study itself. And this is what it looks like. So if you ever come across a patient who has had this done in their NHS practice and you put a gonio lens on them to look at their angles, you'll see the three windows and the shine of the metallic Hydrus. So we move on to our final case. It's a very similar case to the second patient, and actually we'll raise a few questions about that patient as well. But this was a 92-year-old Caucasian gentleman, again, primary open-angle glaucoma, on all the drops possible, had previous trabeculectomy, had previous laser, which wasn't really working. He lived on his own, and he was managing quite well. His visions were very good, his pressures were rising, and his corneal thickness was on the lower side. Pseudophakic, as I mentioned, and the discs were fairly cut. And this is what his visual fields looked like. So he had this quite dense defect, but there was a lot of variability and unreliability in these visual fields. His OCTs weren't too bad. His pressures were quite suboptimal, and actually he wasn't really tolerating taking all the drops as frequently as he was taking. And he too wasn't very keen on the intervention. His response was, "I'm 93, how long further do I have left?" And I felt that was quite sad because he was actually a really good 93-year-old. He did his own groceries, he was very independent, didn't really rely on much help. Other than glaucoma, he was pretty good. And he too was like, "I don't really want anything further done to my eyes." So I said, "Look, well, we could trial the SLT again. So we could do a bit of laser, see if that makes a difference." However, when patients are on many, many drops, the efficacy of that laser is not that great. It lowers, but it's such a safe laser that it can be tried and you may have an effect, but are you just delaying the inevitable? But he wasn't keen on that either. He was like, "I don't want anything. I don't want surgery. I don't even want laser." So again, it made me think, what can I do to slow down this progress that he's having? To make sure that he preserves as much vision as he can for as long as he can. There was a new medication that was introduced called Roclanda recently. And I introduced this. Roclanda is a combination medication of latanoprost and a Rho kinase inhibitor. And I introduced this, and actually his pressures dropped quite nicely after that. And he tolerated the drop quite well, and he was doing very well with it. And that sort of using this alternate drop has actually made a huge difference to him. So as I mentioned, nitazoxanide is the other component of Roclanda, along with latanoprost, which we all know about, which is the prostaglandin analog. And this new mechanism which has come about is actually quite different to what we've had in the past for glaucoma. And what it does is it increases the outflow, but there's also evidence that it impacts venous pressure as well, which is quite unique because no other drop really does that. So you can see these are all the other drops that we have in our arsenal, and none of them actually impact your venous pressure other than the ROCK inhibitors. So it's a really, really good option to have. And at the moment, there's not much awareness of it, but this is a drop that has been NICE approved since last year. And so what they've shown is that actually it's really good at reducing pressure in patients with primary open-angle glaucoma and ocular hypertension, particularly when you've tried other fixed combinations that haven't worked or they're intolerant to beta blockers. And if it's NICE approved, it's because actually the data in the research is showing that it's quite effective. And it showed one of the trials, which I'll briefly touch upon, is that it's as effective as Ganforth, bimatoprost, and timolol. And it's about £10, which is pretty similar to the cost of some of the other drops that we're dispensing. So for NICE, it was a no-brainer. We have this at our disposal. We should be leaning towards this when we have patients like that. And there's an argument that actually case 2, I could have even considered that and taken this patient off the Diamox. But because she has such a small island of vision left, I was more worried that perhaps this again would just delay the inevitable, and we need to do something a little bit more drastic to help prevent this. And this was a trial, so this was a double-blinded, randomized control trial. They looked at about 430 patients, and what they found was that Roclanda was non-inferior to Ganforth. The key side effect that patients have complained about as a result of Roclanda has been conjunctival hyperemia. But in someone like that patient, who fortunately didn't get this side effect, that would be the least of his worries if it means that his pressure stays low, we preserve his visual field, and actually he manages with the 3 lots of drops that he would be in. So from these 3 cases, what I really wanted to take home was actually, the key thing is to think outside the box. And we do have options at our disposal. And sometimes we have to work with the patients, we have to look at their social situation, and we have to try and maintain as much independence for them and give them a good quality of life. It is difficult, but it's very important to work with the patients, especially when they're refusing, and to try and give them that confidence that we could do something to prevent them having visual loss that could impact stuff that they're taking for granted, so even their independence. And sometimes people do lose sight of that, especially when they look at their age. But you have to remind them that even if they are 89 or 93, they're doing so well. And who's to say that they won't survive till 100, 110, 115? So we just have to manage their expectations through that. And it's important that we should always take them through all the options that are available. Thank you for listening.
Well, thank you. Thank you. That was a wonderful interactive lecture. I thank everybody who's on the webinar side for your questions. There is still time to take more questions from the webinar and from the people here at the venue. Would anyone like to make any comments or ask any further questions? Yes.
Will the stent become the main go-to treatment for primary open-angle glaucoma as opposed to drops?
Which stent, sorry?
The stents, the one that you put in.
Yeah, those are quite later on. The main treatment is probably laser. So there's selective laser trabeculoplasty, and that's probably the main treatment option for patients who first present, because it's a one-off treatment. The evidence is amazing that patients can actually go up to 5 to 6 years being drop-free after one particular laser treatment. So if we can offer that straight from their referrals into hospital, that will be very advantageous for them.
Because of the EV changes, do you think that the ROCK-K inhibitors will be the sort of mainline drops in future as opposed to latanoprost?
I think as more and more people start using it and these results start coming out and you start using it in patients with confidence, it will gain popularity because it's a route that's not tackled by some of the other drops. So I believe the popularity will be there, and the evidence that we already have is pretty strong. And I've just shown a real life example of when I've had to use it. So even myself, I'm probably guilty of not using it more often than I should. But yeah, this was quite satisfying to see.
Minak, is Roclanda generally available for prescribing across all NHS trusts, or is it just on a named patient basis?
So the difficulty I've had is getting Roclanda dispensed from certain pharmacies. That's been quite challenging. So patients have struggled to find it, and some GPs, based on their based on the funders of that, so previously known as CCTs or the ICB boards, don't have Roclanda on there. But that's something that we can sort of push to change, especially if it's approved by NICE, but it's not on a patient basis. I think you may find that some sectors just may not be aware of it and just needs to be introduced into the formulary.
So most, in fact, all glaucoma patients are on either 6-month or 12-month review. Do they get the options offered to them, or do they just get seen fields and pressures done and sent home, or do they actually get given the option to go for other treatment?
Yeah, so those that are on 6 to 12 months, often if they are stable, they normally stay in that sort of interval. However, anyone that deteriorates should be seen sooner, and they're often brought in face to face. And if they are, and they're seeing a clinical team, then all options should be discussed with them. So if they want to come off drops, then offering them SLT, the selective laser trabeculoplasty, is really good. All these cases were quite late on their presentations, and so the options were quite extreme. There were surgical options, or putting in stents, or change. I mean, Roclanda, that wasn't a very extreme option, but these were late presentations. But if you're an early presentation, then keeping it to the basics, whether they want drops or laser, and actually trying to push them towards laser is much more beneficial for them.
With the OCT scan, if the RNFL thickness figures decrease, would you refer?
Great question. So with the RNFL, I think it all comes into interpretation. So you have to ensure that it's matching either the visual field, or if the changes are in keeping with a good scan, and if it's truly reflective of glaucoma and not of other optic nerve issues, like whether there's myopia. If you're worried that the pressure is high and there's thinning of the RNFL, then absolutely this could be a good referral point, and you should send patients in. And that could be early signs of recognizing glaucoma and allow us to intervene in a timely manner.
Are there any new treatments on the horizon, such as advanced gene therapy?
Well, I'm sure there's a lot of research. To my knowledge, I don't really know anything that's imminently going to be coming out. Surgically, there's a lot of advances, but gene therapy is very hot. There have been cases where certain genes have been recognized to cause a particular condition, and therefore the surgery has been tailored to that patient. So those that have had something called trabeculotomy has helped reduce the effects of a glaucoma based on a genetic defect. So perhaps when we look at our genetic makeup, we will be able to tailor our treatment in the future to help maximize the effect of that treatment.
If you had primary open-angle glaucoma yourself, what would you want as your first-line treatment, ideally?
Yeah, excellent question. And it will be hands down selective laser trabeculoplasty. So having SLT the evidence shows that it's really good for lowering the pressure, and it would keep me off drops for a period of time. It can be repeated, and it's super safe. So for me, that would be my personal choice. That's what I advise my patients. Understandably, some patients are reluctant to have any form of intervention, so drops are an option. But for me, if I could be without regular drops on a daily basis, SLT hands down.
And SLT is just an outpatient procedure at the slit lamp?
Correct, yeah.
Takes a few seconds, or how long does it take?
Yeah, so SLT is an outpatient procedure, often takes on a maximum 5 minutes per eye, but usually much less. You often have a lens that's applied to the eye where you can see the drainage aspect of the eye, so the trabecular meshwork, which I've demonstrated in some of those videos. And then you just target the laser to go all the way around. So if they're a regular primary open angle glaucoma, then you would target the whole 360. If they're a unique case like pseudoexfoliation, then you would do a slightly more tapered treatment so that they don't have any pressure spikes afterwards.
This fits in very well with the next question. Is SLT advised for advanced glaucoma?
Yeah. Great question. It's definitely an option and can be considered. Often what we find is that patients who have been on long-standing drops, we know from histological studies that those that have SLT on patients who have been on drops, the SLT isn't as effective. Now, there is some argument that it may lower the pressure a bit and could give you more time to work with, maybe give the patient a bit of time to think about any more treatment options that you've already previously discussed, like surgery. So it may buy time, but it certainly won't be a more definitive or long-term treatment. You would, in essence, be kicking the can further down the road. But because it's such a safe option, it's actually good to discuss that as a possible option for these patients who are reluctant to have surgery and just want a bit of time to think about whether going down the surgical route is right for them and their families.
You said that you will do 360 SLT. Wouldn't it be more beneficial to do 180 and see how it goes? And then at least you then got an option of doing the other half rather than going straight in for 360.
You could do that, but we know from the evidence that actually it does pretty well. And logistically speaking, getting patients back on a number of occasions to repeat this, especially those on the NHS, for example, with the wait times, just won't be feasible. So, you know, this is a laser treatment that's had huge landmark study showing that it's very effective. And as long as they don't have a risk factor that could cause a pressure spike, doing 360 in one go is a fairly safe and reasonable treatment option.
There's quite a long question here, so let me read the whole of it. After SLT, would the patient still need to be monitored at the hospital? How frequently? Or usually just see the optometrist on the high street for annual checks? Sometimes patients report that they had surgery for glaucoma and don't need to be seen again in the HES anymore.
Oh, very interesting. So again, in our trust and in our department, if patients have had treatment, so let's start with SLT, for example. If they've had treatment, there will be a period in which we would follow them up. If they don't have any visual field defect and their pressures have normalized, and we've seen over the course of a few attendances, so say 3 as a minimum, that the pressure remains at a reasonable level, then I think it's very reasonable to discharge patients to a community optometrist with the letter explaining the treatment they've had, and they can always come back if their pressure rises. If patients have had surgery, then discharging them to the community is a little bit challenging. Often if they've had, especially glaucoma surgery, these patients do end up becoming long-term patients of the NHS.
Is SLT difficult to apply, he says, through a dense cataract, or if there is a dense cataract present?
Yeah, so the SLT is applied at the in the drainage angle. So hopefully I can maybe bring back one of those images, maybe this one. So you're applying your SLT at this point. So whether you have a dense cataract should not impact the access to this. What it may do is that sometimes when the cataract is well formed or very dense, it could narrow that angle, and then you may not be able to see it as much, but you're not really applying anything through the lens. If that's a question. Yeah, you're targeting the drainage part, the trabecular meshwork.
That's lovely. Are there any other questions? Because we're on time to finish. 1 hour, perfect timing, and such a good interactive conversation with everybody. Absolutely fantastic.
Thank you. Thanks,
Thank you very, very much.
Thank you.
Thank you.
Oh, thank you so much.
It really was an excellent lecture. Thank you.
Thank you.
And so calmly presented.
Thank you.
And you really know your subject, and very gentle I think if I was a 93-year-old, I would be perfectly happy being your patient.
Oh, that's very kind of
Or even a 70-year-old.
very kind of you. Thank you so much.
Thank you. Yeah, you're right.